Dr. Manjula here. Today we will be discussing some questions from previous year questions from medical surgical nursing, obviously from these chapters, that is cardiovascular system, musculoskeletal system, renal system, neuro, opthal and respiratory. So the first question is, the best indicator for estimating adequacy of fluid replacement in the acute phase of burns: serum sodium, serum potassium, sunken eyes, urine output. Tell me which is the answer. How do you know that after the fluid replacement, how do you know that the fluid replacement is effective in the acute phase of burns? What is the answer? It is urine output. So urine output will show that your fluid replacement is adequate and the renal perfusion is being restored. Next question, a polypeptide hormone produced by the parafollicular C cells of the thyroid gland, which is that calcitonin, thyroxine, triiodothyronine and parathormone. So it is a polypeptide hormone produced by the C cells of the thyroid. It is easy to remember. Calcitonin. We have already discussed in our theory classes also. CC, calcitonin, is the answer. Okay, so what is the role of calcitonin? It is to maintain the calcium homeostasis or the balance in the body. How does it maintain? It is primarily by lowering the blood calcium levels. How does it lower the blood calcium levels? There are two things here. One is by inhibiting the osteoclast. You know, osteoclast are the cells, bone cells, which are responsible for breakage of the bone or resorption of the bone. So when this calcitonin actually inhibits that process, so it obviously decreases the calcium levels. And the second thing is, it increases or it promotes the calcium excretion through the kidneys. So the kidneys starts through the kidneys, the calcium is lost, and also it prevents the calcium being lost from the bones or taking the calcium from the bones into the bloodstream. So these two processes it stops, and that is how the calcium levels are lowered in the blood. So the calcitonin, what is the action of calcitonin? To lower the calcium levels in the blood or the body. How does it do? It prevents the osteoclastic activity, and second thing is it promotes the kidneys to excrete more of calcium. Which is the fifth cranial nerve? Facial, olfactory, optic, trigeminal. Direct question, trigeminal. So this, all the 12 cranial nerves you should study. What are the names, the numbers, what is its action, whether it is a purely sensory, purely motor, or it is a mixed one. These are the questions you can get from the cranial nerves. Then pepsinogen is secreted by chief cells, parietal cells, goblet cells, pancreas. So where pepsinogen is secreted by which cells? By the chief cells. Next question, bacillus of tuberculosis was detected by Robert Koch, Louis Pasteur, Hansen and Neisser. Again a very direct question, Robert Koch. Next question, normal flora in our body, which is there in our body, it remains there always without causing any harm to your body. It is called as commensals, saprophytes, true pathogens, facultative pathogens. So the normal flora which remains in your body, which does not cause any trouble to you, is called as commensals. Next question, spherical or oval shaped bacteria. They are called as Bacilla, Spirilla, Cocci and Vibrios. So round shaped ones are called as Cocci. Next question, modified acid fast staining commonly used for staining Mycobacterium tuberculosis. Gram stain, negative stain, Ziehl-Neelsen staining, none of the above. Can you tell me what is the answer? The staining technique that we use for Mycobacterium tuberculosis. Which is the one? The answer is C. Ziehl-Neelsen staining. Next question. What should a rescuer do after the AED, automatic external defibrillator, delivers shock by doing BLS or ACLS? Read the question carefully. After you are giving the shock or defibrillation, automated external defibrillation, what should you do? Okay, immediately check the carotid pulse for no more than 10 seconds. Immediately restart CPR, beginning with chest compressions. Wait for the AED to reanalyze the rhythm. Provide 2 breaths to the victim. Okay, this you should be able to answer. Tell me. Soon after AED, what you should do? There could be a lot of questions from this area, CPR. If there is one rescuer, how many breaths you give, how many compressions you give. There are 2 rescuers, how much you have to compress. All these are the questions which can be asked. So one such question is this: after AED, soon after AED, what you should do? You should immediately start CPR. You should not wait for anything else. Immediately restart the CPR with chest compressions. Next question. Which of the following findings would the nurse expect to assess in hypercalcemia? So when there is hypercalcemia, what is your assessment? Prolonged QRS complex, tetany, petechiae and urinary calculi. Obviously, you know that tetany is out of question because you know it is hypocalcemia. Then petechiae, it is because of some breakage in the capillaries underneath the skin. So that also you cannot find in hypercalcemia. Then between these two, which is the answer? So after eliminating 2 choices between A and D, which is the answer? The answer is urinary calculi, because in hypercalcemia what happens? The more calcium gets deposited either in the soft tissues or in the kidneys, resulting in urinary calculi. Okay. Next question, a client with end stage renal disease is admitted in the nephrology ward and his serum potassium is 6.6 milliequivalents per liter. What should the nurse assess first? So you know that the potassium level is 6.6, that means hyperkalemia. So in that case, what should the nurse assess first? Cardiac rhythm, blood pressure, respiration, urine output. So when the nurse knows that there is hyperkalemia, it should come to her mind that hyperkalemia will cause cardiac arrhythmias. So the first thing what she should assess is just check the cardiac rhythm. Next question, in a health education session, a nurse explains reasons for chronic cough except angiotensin converting enzyme inhibitor usage, chronic smoking, beta blockers, chronic bronchitis. So in which of these conditions there is, see, read the question very carefully. Don't get confused. The nurse explains reason for chronic cough except. So there is chronic cough among the 4 options. There is chronic cough in 3 conditions except 1. The question is, which is that one answer which does not cause chronic cough? Okay, angiotensin converting enzyme inhibitors, they do cause chronic cough. Smoking, chronic smoking, yes, we are all aware that it causes chronic cough. Beta blockers, yes or no? Let it be there. And chronic bronchitis, does it cause chronic cough? Yes, the definition of chronic bronchitis itself is like that, right? Chronic cough for more than 3 months for 2 consecutive years is the feature of chronic bronchitis. So then the only option that is remaining is beta blocker. Okay, beta blocker will cause not chronic cough. It will cause respiratory difficulties, or it will cause wheezing, or it will cause shortness of breath, but not chronic cough. Okay, so this angiotensin enzyme converting enzyme inhibitors causes dry cough as its side effect. What are the drugs? Enalapril, lisinopril, that pril, whatever comes, falls under AC inhibitors. Then chronic smoking, because it irritates the respiratory tract. Then chronic bronchitis, obviously chronic cough and mucus production with for at least 3 months in 2 consecutive years. And beta blockers actually non-selective, there are two different types, right? Selective and non-selective beta blockers. Selective beta blockers will act only on the beta 1 receptors, which are mostly found in the heart and the blood vessels. And so when you are giving selective beta blockers, it will not cause any respiratory problem. But if you are giving non-selective beta blockers like propranolol, then it will cause asthma or wheezing, exacerbate those respiratory problems. Okay, so this can also be a question which can be asked, very important, about beta blockers, selective and non-selective, or beta blocker 1 and receptor 1 and 2. Next question, which of the following vitamin functions like a steroid hormone? Vitamin A, B1, C, D. Vitamin D is the one which functions like a steroid hormone. Next question, which of the following mineral element causes pathological changes in bones and teeth in its excess as well as deficiency? So one of these particular mineral, when it is excess also it causes teeth problem, when it is deficient also it causes teeth problem, which is the one? Chlorine, fluorine, zinc, copper. So teeth health is associated with fluorine. Next question, normal endotracheal carbon dioxide value of an intubated patient is 60 to 70, 35 to 45, 20 to 30, 25 to 35. So he has an endotracheal tube, and in that the carbon dioxide value is 35 to 45 millimeters of mercury. Next question, metabolic emergency that is frequently found in small cell lung cancer. Small cell lung cancer. SAID, syndrome of inappropriate antidiuretic hormone. A is missing. Syndrome of inappropriate antidiuretic hormone, hypercalcemia, metabolic encephalopathy, tumor lysis syndrome. So in small cell lung cancer, one peculiar feature is that it will cause, due to ADH deficiency, it will cause syndrome of inappropriate antidiuretic hormone. Okay, so hypercalcemia actually is seen in squamous cell carcinoma, not small cell lung cancer. Okay, so please remember that hypercalcemia is found in squamous cell carcinoma, more common in squamous cell carcinoma. Then metabolic encephalopathy is seen in advanced cancer, but it's not very specific to small cell lung cancer because it can happen in any type of lung cancer, not very particular or specific about small cell lung cancer. Then how about tumor lysis syndrome? Tumor lysis syndrome is mostly seen in hematologic malignancies like leukemia, lymphoma, etc., rather than lung cancer. Okay, so please understand that syndrome of inappropriate antidiuretic hormone is the metabolic emergency that can happen in patients with small cell lung cancer. All the other things are not very specific about small cell lung cancer. Next one, immune reaction occurring in blood transfusion is a type of microangiopathic reaction, autoimmune reaction, macroangiopathic reaction, isoimmune reaction. So, what kind of reaction happens after blood transfusion? Microangiopathic reaction, autoimmune, it is not autoimmune, we know that. Macroangiopathic or isoimmune reaction. So the answer is what? Just can you just message in the chat box? What is the answer? The answer is isoimmune reaction. Okay, isoimmune reaction. Isoimmune means you are getting a reaction to the antigens from the same species, actually, or say from another person of the same species. So you are when you are getting blood transfusion, you are actually transfusing, or you are getting the antigens of another person but of the same species, right? From another human being only you are taking. So such reactions are called as isoimmune reactions. So when your body reacts to antigen that comes from a different person of the same species, means another human being, then your body goes into isoimmune reaction. Okay, what about autoimmune reaction? Your body is producing antibodies against your own body, right? So autoimmune, that is what here. Autoimmune reaction means your own body cells are being attacked. So as in case of autoimmune hemolytic anemia, where your body will dissolve or break down your own RBCs. So, but what happens in your in blood transfusion? What happens? There is a foreign RBC, right? It is not your own RBCs. It is a foreign RBC. So your body will try to attack those foreign RBCs which are produced or which are there in your body. So that is called as isoimmune reaction. So please don't get confused between isoimmune reaction and autoimmune reaction. Autoimmune reaction means your body fights against your own body cells or your own RBCs. Okay, that is called autoimmune hemolysis. But in isoimmune hemolysis, what happens? Somebody else's RBC, which is already there in your body through blood transfusion, your body fights with that. I hope it is clear to you both autoimmune and isoimmune. Then microangiopathic reaction means what? Micro means small, angio means blood vessels. So small blood vessels are being damaged, like as in case of disseminated intravascular coagulopathy, then thrombocytopenic purpura. All these conditions, small blood vessels are being broken down or damaged. So that condition is called as microangiopathy, okay, or microangiopathic reaction. Macroangiopathy means what? Macro means big, angio means blood vessels. Bigger blood vessels are being affected, as in case of atherosclerosis. So larger blood vessels are affected there. I hope it is clear. All the four conditions are clear, right? Yes? Fine. Next question. Post myocardial infarction, a patient complains of chest pain along with increased deep breath. So which nursing action is appropriate? So after MI, the patient is complaining of chest pain, which increases when he is taking a deep breath. Can anybody guess what is that condition called as? What could be the diagnosis if you get this symptom after MI, post MI? Yes? Can you just answer what is that condition called as? Okay. Okay, we'll come to that. So after MI, he's getting chest pain every time he breathes deeply. So what should you do? Obtain vital signs and auscultate for pericardial friction rub. Obtain 12-lead ECG and inform the physician immediately. Give high flow oxygen. Give SOS analgesic and observe for 30 minutes. So the answer is what? So when this patient has this symptom, that is chest pain, when he takes deep breath, that is an indication of pericardial inflammation, or we call it as Dressler's syndrome, which is a complication that is developed after getting MI, Dressler's syndrome. So the answer should be we have to auscultate for pericardial friction rub, so that when the inflamed layers of pericardium are rubbing against each other, then you get this leathery kind of sound, pericardial friction rub. So the answer is that. So in post-MI, patient experiences chest pain that worsens with deep breathing. That is suggestive of pericarditis, or the another name is Dressler syndrome. Next one, lowest possible dose of epoetin alpha or erythropoietin alpha is used to treat anemia in chronic kidney disease because that means low dose is used to treat anemia. You know that in chronic renal failure there is every chance of developing anemia because of the suppression of the bone marrow and all of those things. So we usually give epoetin to stimulate the production of RBCs. So it is given in the lowest possible dose. The question is why you are doing that. So high dose is associated with high rate of thromboembolic events, because it is highly hypersensitive. Third thing is minimum dose can stimulate erythropoietin production and it is costly. Fourth one is nephrotoxic in nature. So what is the reason that
ചേട്ടാ നാളെ പോണ്ടേ? ജോജി ഇംഗ്ലീഷ് കേട്ടിച്ച് പഠിക്കത്തേ പോ. തിങ്കളാഴ്ച ഇംഗ്ലീഷ് കൊണ്ട്
Okay, so why do you give the lowest possible levels of erythropoietin when you want to treat anemia in chronic renal failure? What is the answer? The answer is okay. Okay, so why do you want to give low dose of erythropoietin when you are treating anemia in CRF? The answer is high dose, because if you give high dose, it is associated with thromboembolic phenomena. Next question. Accumulation of hydrophilic mucopolysaccharides in the dermis and other tissues is seen in scleroderma, SLE, elephantiasis, myxedema. So the tissues, there is a lot of accumulation of mucopolysaccharides, hydrophilic, which will absorb or keep water molecules to it. Hydrophilic means it likes water. So such kind of mucopolysaccharides are seen in the dermis of which of these patients? So the patients with myxedema, they have, the characteristic features of myxedema, puffiness in and around the eyes and facial puffiness, all of those things. So such patients develop hydrophilic mucopolysaccharides in their dermis. Next question. This is very, very important area. ABG analysis. You may get values and to interpret it. It is very easy. With little practice, you can master it and you can gain marks. So here the question goes like this. ABG value of a patient shows pH is 7, PO2 is 90, PaC2O is 23, and the bicarbonate is 12. So what does this indicate? Compensated respiratory acidosis, uncompensated metabolic acidosis, partly compensated metabolic acidosis, partly compensated respiratory acidosis. So now this you have to tell me. You can put the answer in the chat box. What does it show? Is it, first what you should do? You should look at the pH. Is it acidic, alkaline? What is it? It is acidic, right? pH of 7 is acidic. And is it normal or abnormal? 7 pH is actually, it is not falling into the normal 7.35, 7.45, right? So it is still acidic. Then what you should do? You should look at the bicarbonates, the carbon dioxide, the oxygen, the carbon dioxide and the bicarbonate. Now you see that the carbon dioxide is low, correct? 23 is low. and bicarbonate is very, very low, 12 milliequivalents. So now you look at the answer. The pH is 7, which shows that it is acidosis. PaCO2 is low, means normal is 35 to 45, but here it is 23, and the bicarbonate is also low. Normal is 22 to 26. Now what you have to identify first is what is the primary problem that we have to see the pH and also the carbon dioxide and the oxygen value. So here we know that the bicarbonate is low, acidosis, it is acidosis. And what is the reason for here acidosis? It is because the bicarbonate is low. Acidosis can happen if the carbon dioxide level is high. Correct? If PCO2 is high, it can also, you can see the acidosis. That condition is called as respiratory acidosis. And the second reason for acidosis is metabolic acidosis, where you can see that the bicarbonate will be low. I think you know the synonym like this, mnemonic like this. ROM, you can remember it like ROM. ROM, R stands for respiratory disorder. Then your it moves in opposite direction. pH and PaCO2 moves in opposite direction, but in metabolic disorders, both move in the equal direction. Either it will be, both will be up or both will be down. What is that? Both pH and bicarbonate. Now this is an easy way to remember. Okay, ROM, respiratory problems or respiratory disorders, the pH and the carbon dioxide will move in the opposite directions. In metabolic disorder, the pH and the bicarbonate will move in the same direction, either both down or both up. So coming back again to this, the pH is 7, carbon dioxide is 23, which is low, bicarbonate is very, very low, 12. So the reason here is because of the low bicarbonate, the patient has developed acidosis. So the cause here or the disorder here is metabolic acidosis. So that is the primary problem. Now you want to see whether it is compensated or not. It can be fully compensated, partially compensated, or uncompensated. Now you have to look at it like this. So here it is a metabolic problem. So the other organ will try to compensate it. That means when there is a metabolic acidosis, the lung will try to compensate it. So here you can see that the carbon dioxide value has literally gone down from the normal. That means the lung is trying to compensate. Okay. Suppose the PaCO2 value was within any of these, like between 35 and 45, then you know that the lung is not doing anything. It is just keeping quiet. So that time you can say that it is not compensating. But here in this condition, you can see that the PaCO2 is low. That means the lung is trying to compensate or trying to bring the homeostasis to the normal level as much as possible. But so the lung is trying to compensate. There is a compensation happening. Then how do you know whether it is fully, partially, or uncompensated? Now here you know that it is not uncompensated, because there is, you can see there is a compensation happening here. So it is compensating, but whether it is full or partial, how will you know? Again, go back to pH value. pH is low, it is still acidic. So that means it is not pulled into that normal levels of between 7.35 to 7.45. The pH is still abnormal. So that means it is partially compensated. Is that clear? I think it is easy for you to understand whether it is metabolic or respiratory problem. But when it comes to compensation, this is how you see it. Look at the opposite organ, and if those values are abnormal, then you can say that it is compensating. And how do you know whether it is partial or complete? Again, look at the pH. If the pH is still abnormal, it is partially compensated. If the pH is falling into the normal value, then it is fully compensated. I hope it is clear. Okay, next question. A patient complains of drawing sensation on one side of the face followed by paralysis of all ipsilateral muscles. Ipsilateral means same side. Which among the following is the most possible diagnosis? Tic doulorex, Bell's palsy, Meniere's disease, glossopharyngeal neuralgia. So you see that patient's one side is completely paralyzed and he is getting a drawing sensation, a pulling sensation, a discomfort on one side of the face. So which is the possible diagnosis? Tics, or it is otherwise called as trigeminal neuralgia. Tic doulorex, Bell's palsy, Meniere's disease, glossopharyngeal neuralgia, which is the condition when one side is paralyzed. The answer is Bell's palsy. So in this picture, you can see that there is a drooping of the eyebrow, drooping of the eyelid. You can see there is a drooping of the eyelid and the drooping of this corner of the mouth. So this whole side there is paralysis or drooping. So that is called as Bell's palsy. Next condition, pterygium can be defined as, pterygium is the condition of the eyes, ophthalmic condition. It can be defined as white deposits found in the cornea, fleshy triangular shaped growth on the conjunctiva, cyst in the conjunctiva, scarring of the cornea. Yes, what is the answer? Pterygium. Pterygium is the condition of the eye, and what is it? How is it defined? It is the fleshy triangular shaped growth on the conjunctiva. See, this is how it looks. You can see here there is a flesh-like thing growth in the conjunctiva. Next question, the most potent stimulus for medullary chemoreceptors is decreased PO2 in the blood, increased H+ concentration in the blood, increased PCO2 in the CSF, increased H+ concentration in the CSF. This is a question in last year's question paper 2024. So you can answer this one. Medullary most potent stimulus. Okay, most potent stimulus for, so the key word is here, the most potent stimulus for medullary chemoreceptor is, what is it? Decreased PO2, increased H+ in the blood, increased PCO2 in the CSF, increased H+ in the CSF. Which is the answer? Can you try? Increased H+ concentration. Yes, increased H+ concentration in the CSF. Okay. Increased H+ concentration in the CSF. Now, okay. So the medullary chemoreceptors, little bit about that. They are actually, where is it located? Medulla oblongata. And what it does is, it monitors the pH of the CSF, and that is how it regulates the breathing. Okay, so it is sensitive to the H+ of, or the pH of CSF. Now, the answer is increased H+ concentration in the CSF. That is the answer. You know, a little bit I would like to explain on that. See, carbon dioxide, it can easily pass the blood-brain barrier, but H+ ions or bicarbonates cannot. So carbon dioxide will easily pass the blood-brain barrier, and in CSF, it will combine with water, forms the weak carbonic acid, then it will split, dissociate into H+ ions and bicarbonates. Okay, that is what happens when carbon dioxide mixes with water. So it easily will cross the blood-brain barrier and it will react with water, forming the weak acid, that is the carbonic acid, which immediately will dissociate into H plus ions and bicarbonate ions. Now, so you have plenty of H plus ions here, right? Which is already present in the CSF. Is that clear? H plus alone cannot cross the blood-brain barrier. No. Here, carbon dioxide can easily cross the blood-brain barrier. When it reaches the CSF, and when it reaches the brain, it will react with the water in the CSF, causing a weak acid called as the carbonic acid. This carbonic acid splits or breaks into H plus ions and bicarbonate. That is how the H plus comes there. Okay, it is not that H plus goes into the CSF. No, it is the carbon dioxide which crosses and reaches the CSF, where it will later on split into and forms H plus ions. Okay, that is how the H plus comes there. Now, our medullary receptors, chemoreceptors, are very, very sensitive to these H plus. That is, it just remains, it watches how the H plus ion concentration, accordingly it will regulate the respirations. So our increased H plus in the CSF directly stimulates the central chemoreceptor. These are actually central chemoreceptors, okay? The medullary chemoreceptors are also known as the central chemoreceptors. And that is the reason for triggering increased respiratory rate. And thereby you eliminate the carbon dioxide. Is that clear? Once again, I will explain to you. See, in your body, when you, for example, when you are going into hypoventilation, your respirations are ineffective, your respiratory rate has become like 10, 12 like that, and you are going into hypoventilation. So what happens in the body? Carbon dioxide gets accumulated, right? This carbon dioxide will cross the blood-brain barrier, reaches the CSF. CSF, it is completely water, correct? So this carbon dioxide will combine with the water in the CSF, forming a weak acid called as carbonic acid. This carbonic acid will split into H plus ions and bicarbonate ions. This H plus ions is the one which is to which our chemoreceptors, medullary chemoreceptors, are sensitive to. So the medullary chemoreceptors will watch the number of H plus ions. If it is increasing more and more, what does that mean? When the H plus ions are more, what does that mean? There is more carbon dioxide in the body, correct? Yes or no? When there is more carbon dioxide in the body, more H plus ion forms in the body, right? So this will stimulate the central chemoreceptors and it will cause the respirations to become faster so that the carbon dioxide will be blown out through the lungs. This is how it happens. Okay, so the answer is what? The answer is increased H plus ion concentration in the CSF. Now, you may also see here the choice C. You may think that that is also correct. This is how people make distractors to make you choose the wrong answer. Now, out of these two, which is the best answer or the most accurate answer? It is the fourth one, correct? Because just before this, what happens in the body, our carbon dioxide level, sorry, not this, this one. Increased carbon dioxide level, in your body, the carbon dioxide level increases and that will also increase the H plus ion concentration in the blood. But our body is sensitive to, or the central chemoreceptors are sensitive to H plus ion concentration in the CSF. Okay, so CSF, this is very, very important. H plus ion, don't just think that it is H plus ion concentration in the body. No, it is H plus ion concentration in the CSF. It is not this, but it is CSF. Okay, this we have already discussed. Next question. Choose the incorrect statement about blood group. Incorrect. Okay, incorrect. Landsteiner law is applicable to all blood group systems. Only naturally occurring antibodies are A and B. Rh antibody is found only after sensitization. O negative blood group is universal donor. Which is false among these? Which is not correct among these? It's a very direct question. The answer is A. If you know Landsteiner's law, you know that it is not applicable. It is applicable only to A, B and O. It is not applicable to RH, correct? And how about this? Only naturally occurring antibodies are A and B. Yes or no? Your naturally occurring antibodies are A and B. That is correct. Then RH, how it is formed RH antibody? It is after sensitization. Otherwise, it doesn't develop. And O is universal donor. So the answer is Landsteiner law is applicable only to ABO, not to all groups. So what does the law say? It says that if you have, please remember this, please remember, if you have antigen A, then you won't have anti-A antibodies. And the same for B also. And if you lack an antigen, you will have its natural antibody. That is, O has got anti-A and anti-B. So this is very direct question, and I hope you all know this. And RH develops only after an exposure. Next one, the sensitization transmitted by lateral spinothalamic pathway is sensation. Which sensation is transmitted through lateral spinothalamic pathway? Vibration, pain, fine touch, pressure. Yes, what is the answer? Which sensation is transmitted to the lateral through the lateral spinothalamic pathway? Vibration, pain, fine touch, pressure. It is pain and temperature. Okay. So the lateral spinothalamic pathway transmits pain, both dull and sharp, as well as temperature. Now, to understand the spinothalamic pathway, you can have a look at this picture. There are three neurons here involved. See, from the skin receptor, first neuron, or it is called as the first order neuron, sensory neuron, which goes or takes the impulses from the skin receptors, and it will go to the posterior or the dorsal ganglion. Okay, so the first order neuron transmits in the dorsal root ganglion. It will transmit to the spinal cord through the dorsal root ganglion. Now you see this picture. This is the dorsum. This is the ventral area. This is the dorsal area. So here you can see the ganglion, the dorsal root ganglion, and through that area it comes to the dorsal horn. Okay, so it comes to the dorsal horn and it starts the second order neuron. So there the second order neuron crosses to the opposite side and then it goes up. See the picture, the second order neuron, this is the red one. So from here, from the left, it goes to the right. So it crosses here. Okay, it crosses and then it goes up through the spinothalamic tract and it reaches the thalamus. Then from the thalamus, another third order neuron, or it is also called as interneuron, which carries the impulses to the cortex, the cerebral cortex, to perceive the pain as well as the temperature. So this is the, in a very simple way, how the lateral spinothalamic tract works. There are three neurons, first order, second order, and the third order neurons. So the second order neuron takes it to the thalamus, where it is transmitted to the third order neuron, to the cortex, somatosensory cortex, where you can perceive the pain and the temperature. Is that clear? So this is the picture, I think this is very, very simple picture which you can easily make out. First order is from the skin to the posterior ganglion here, and then it crosses to the opposite side, the second order neuron, it goes up to the thalamus, and the third order from the thalamus to the brain cortex, right? So this is the lateral spinothalamic tract, and what it perceives the pain and temperature. Now the other choices, that is vibration. Vibration is transmitted by DCML or dorsal column medial lemniscus pathway, not the spinothalamic pathway. Same way, fine touch also is transmitted by DCML pathway. Pressure is, again, especially deep pressure is transmitted by DCML pathway. Okay, so and the crude touch is by the anterior spinothalamic tract. So these things please remember. So vibration, fine touch, pressure, and even deep pressure is through DCML pathway or dorsal column medial lemniscus pathway, and crude touch is through anterior spinothalamic pathway. Okay, so that is about today's class. So thank you very much.